First of all, I want to thank my friend and dear colleague, Dr. Peter Tawil, who gave me the opportunity today to give this presentation in this amazing webinar on dent links. I'm happy to be in this prestigious clinic to talk about a topic that I love a lot, which is the endodontic anatomy. The anatomy in general is a very important topic in dentistry. And we all know that when we start dentistry, dental school, we start with the anatomy, with the sculpture of the teeth. And it is even more important when we are talking about endodontics. Because the endodontic anatomy is a hidden anatomy. This is the idea, what we have of the endodontic anatomy. It's something which is hidden. But we know now, and not now only, for centuries, for 1 century, we know from these images done by Dr. Hess and his students of dye penetration inside the root canals, we know that the system, the endodontic system, is an amazing system. It's a very complex system, as you can see on these images. Now, from these images, 2 schools emerged. The first school was, in my opinion, a giving up school. People thought that because the anatomy, with his fellow student also, like West and Buchanan or Ruddle, these guys thought that, okay, anatomy is very difficult. It is true. But maybe we can find a way to treat this difficult anatomy in tri-dimension. And these cases are cases done 50 years ago by Herbert Schilder. The problem was with these cases, the theory was here, but the technique was not present because we didn't have the material to do well this, to work well on this anatomy quickly and efficiently. That's why it was very difficult for students to learn how to do endo on molars, for example. Today, we have the theory, we have the concepts, and we have also the tools. Tools meaning magnification, so we can see maybe 50% or 60% more of the anatomy of the teeth with this magnification, microscope or loupes. We have will give us the opportunity to have a direct clinical consequences, which are a feasible, repeatable, and teachable way to treat the teeth and to have possibility to clean all the lateral canals and to have a good prognosis of our treatment. But to do so, we need to take a tooth globally. And the biggest error endodontists did, and students do, even nowadays, is to think only about the apical part. They want to reach the apical part. This is an obsession. When we work like this, we will forget the globality of the treatment, which is a globality of not only the endodontic treatment, but even of the restoration. That's why the access cavity is the key part of the treatment, because it is our way to the canals. For example, you can see on the left mandibular molar, we cleaned the isthmus of this molar. By cleaning the isthmus, we could find the sometimes, and especially on retreatment cases, we can just by correcting the access cavity, we can have the access to all the canals. If we look at this premolar, we can see that on the previous treatment, the dentist went only on one canal. And it is obvious because this canal is completely excentered. So just by correcting the coronal part with a small burr or ultrasound, and I will show you later about ultrasound, we will be able to go inside the other canal. The other canal was easier than the first one because it is a straight canal, and it was possible for us to shape, clean, and fill these canals. So we have variations, and these variations are not specific to one tooth or another. We know that lower premolars they have lots of variation, but even on molars. This is an interesting case because it was done by a friend of mine, and he's a good dentist. So you can see that he did on the first X-ray, he did an obturation on the first on one of the canals, and at the end he took an X-ray and he saw that it was completely excentered. So he sent me the patient and told me, look, a special care should be given to the access cavity preparation, meaning that we don't use only burrs for the access cavity preparation. Most of the time, the biggest part of the cavity is prepared with ultrasound. Here I am using a tip, which is the ET18 from Acteon, which is replacing for me the EndoZ burr, because I have better control with something not working very quickly and with something that I can see, because when you use a burr, you cannot see. And we have to take in consideration that every case is different from another one. Here, for example, we have this central. It's a classic case of a central who had undergone a trauma long time ago. So we have a calcification in the coronal part. In a case like this one, it is very important to use a round, small surgical burr, long burr, because by using this long burr, we are able to see what we are doing. Perforations are very easy to be done on centrals because of the positioning of the tooth. So we go very slowly with this burr, and looking on the microscope, we can go very slowly. At one point, we will see a small pulp exposure. The biggest error here is to take a burr and to try to enlarge it, because we will have at this moment very large coronal part and without continuity between the coronal and the apical. So in this case also we use ultrasound. Ultrasound a must in all cases, especially in retreatments. Here, for example, in this case, there is two canals. One of them are missed canals, and the other one is not well obturated, as you can see. Using ultrasound, here another one, it's an ET20. We can see now the two dots of gutta percha very easily. The first file is, we put first file in the first dot, and then on the second one, we can see the second dot, which is very eccentric. But by looking, we can find it very easily, and these are the two files inside the canal. At this moment, we can use any system that we want. Here I am using the reciprocal glue system because these are large canals, but we can use any system to shape these two canals that are joined in the apical part. So it's a Vertici class 2 configuration. So in the axis, what we need to do, and this is a key point in my presentation, is to adapt ourselves to any case. And here, for example, on this X-ray, you can see on this lower 7 that there is an extra root. So by looking well at the X-ray, I can search for it with the microscope very well, because this extra root can be everywhere. As you can see, it is very close. The orifice of this root is very close to the mesial roots, which is really uncommon. If I didn't look at the X-ray well and I didn't see this root, sometimes we need to take even CBCT to look very well at the anatomy. I can miss this canal and I will have, of course, a failure. And this is the treatment at the end. You can see how the three canals on the mesial part are close, one each to the other one. So, talking about the pulpal floor, it is very important to look very well at this floor when we are searching for canals. And here I'm going to talk about one very important tooth that we treat a lot, which is the maxillary molar. You all know that years ago, clinicians, they thought or they tried to forget that there is another canal and the maxillary mesial molar. Nowadays, we all know that there is 4 canals most of the time in maxillary molars. And if we look at some publications, we will see some numbers about this MB2, mesiopalatal canal. They talk about a distance between, for example, the MB1 and the MB2 of 2 millimeters or a distance of 3.5 millimeters. But what does it mean, this clinically? It is just a mean value. Clinically, what I need to do is to look at every case, because every case is different from the other one. For example, in this one, the distance between the MB1 and MB2 is very, very small, and they are very far from the palatal canal. Sometimes they are in the same orifice. And here I am showing two opposite cases. The first one is a young patient with very large canals, a retreatment case. On the second one, it's not a retreatment case, but it is more difficult. Why? Because we don't even see the canals on the X-ray. So they are very thin canals. So the treatment for the obturation. Here you can see for the first case, for example, the canal orifice of the MB2. The MB2 here, the distance between MB1 and MB2 is equal to the distance between MB2 and the palatal canal. And if you look at the geography of the pulpal floor, it is very unclear. Here you can see the difference is that the distance between the MB1 and MB2 is higher than the distance between the MB2 and the palatal. So the MB2 is very close to the palatal. So we have to search the MB2 at this point. And even in the shaping parts. On the first one, very large canals, I go directly, in cases like this one, I go directly with rotary instrumentation or reciprocation. I don't use any hand files because I don't need to. The canal is very large. We go with a glide pass, which here is a R pilot in reciprocation, and then just taking the length with hand files. After taking the length, we can prepare all the canal with rotary instrumentation, which is not exactly the same for the other molar, because on the other molars the canals are very thin. So I prefer personally to go with very small files first, just to do a scouting, to make sure of the patency of these canals. And after doing the scouting, I can then switch to a system. But here, in a case like this one, I don't like to use a single file instrumentation like the reciproc, because this instrumentation, like the reciproc, they are tapered, 8% taper. So there is a risk of fracture of the instrument or a stress on the instrument or canal transportation. In cases like this one, I prefer to use a system like the two-shape, doing a crown down first with one flare, then a glide pass, and after the glide pass, we can use a 4% system, which is another important is to consider that all the anatomy that we are treating is unconventional. this is the easiest way to treat endodontic treatment, because if we think like this, everything will be easy. This is a lower premolar, for example. It is a two-rooted premolar, but it's not that difficult because the two canals are visible in the coronal part. So just by looking at the X-ray, we can then do the glide path using another instrument here. I am using the Pro Glider, for example. It is a 16% tapered instrument, which will prepare the road for a single file instrumentation, which is the reciproc blue here, heat treated instrument. And this is the case at the end of the treatment. You can see the lateral canal obturated, where there is a deletion. Other uncommon case, upper premolars. Here, an upper premolar with a caspose and core. And notice how one of the roots is small. So it is very different of what we see usually. But it's not a problem, we adapt ourselves. Here again, I am using the two-shape system. This is the TS2 working. I like to use this instrument because it is very efficient on brushing in the coronal part. And brushing is very important in the coronal part because it will remove all the stress from the instrument in the apical part where we don't use brushing because we don't want to do any transportations of these canals. And this is the case at the end after the obturation. Another uncommon situation is the deep split situation, which means that there is one canal starting from the orifice of the other canal. This is the case of the premolar. If we do, it's even more difficult because the deep split is really apical. And in cases like this one, we need to cut the cone very far inside the apical part, the first one, to be able to place the other cone on the second part, and the second one. The deep split can be with 3 branches, like here. I call this case the never-ending canals because I thought it was an easy case, and I found MB1, MB2, and MB3. One of the MBs were joining the other one, but then I went to the palatal canal. There was a lot of bleeding, and it was really huge, very large. I didn't enlarge this canal. It was just like that. And I started cleaning, using cleaning and activation in these canals, and removing all the tissue from there to access, by scouting in the apical 3 branches of this upper molar. Another topic in anatomy, when we talk about anatomy, it's curves canals. When I started endodontics and when I was a student, cases like this one, I was sometimes afraid how to deal with it, how to deal with them. Nowadays, because we have tools and I have more experience, I am enthusiastic. When I see cases like this one, I am happy. And I know that I have lots of instrumentation that I can adapt to this anatomy. Here, for example, a number 15 file were going inside the canal. So this curve is not that difficult. And I went inside this curve with a 6% in this case. Would you go with a 6% instrumentation in a curve like this one? I don't think so. Would you go with a 4%? In my opinion, no. Because by doing this, we will or fracture the instrument, or do a ledge, or do a canal transportations. So I adapted myself to the anatomy by using only 2%. I used only in the apical part pass files in this case, meaning 2% instrumentation, working lots of them, and to be able to clean the system. Of course, it's not large like the other cases because the anatomy of these tools is like that. So anatomy is the king. We need to adapt ourselves to this. And the cases can be more complex because on the same tooth, we can have several types of anatomies. You can see on these lower molars, on upper molars, we can have sharp curves in the apical part, as you can see here, sharp curves, or homogeneous curves. Homogeneous curves are easy to deal with. Why? Because our instrumentation, here I was using the Wave 1 gold instrument, which is a great instrument in cases of homogeneous curves. We can go with very high taper instrument in these curves without any transportation. But in apical sharp curves, we need to work only with hand files because the instrument, the night eye file, cannot bend there to go there inside this curvature. And some Sometimes the curvature is not only one curvature. We can have an S-shaped curvature like here, meaning we have two curvatures. And when we have two curvatures, we need to have a special protocol also. So here I am going, I do one curvature on a time. So I'm going with a very small file, and then I'm using one flare just in the coronal part to remove the maximum of tissue there and to enlarge this coronal part because I want to remove all the stress on the instrument to go to the apical part easily. Here I am doing my part of my irrigation, of course. Irrigation is very important. Then I take the lens with a 31 millimeter file. And here you can see on the file the curvature. I like these photos because you can see exactly how is the curvature. And the case like this one, the glide path instrument that I used is a very flexible one. It is Wave 1 gold glider working in reciprocation. So in this case I use reciprocation in the first part. Here you can see in both canals. These canals were joining. So when canals are joining, it's very easy because we have only one apical exit, but it is difficult because we can have a fracture of the instrument at the joining point. So we have to use new instruments. And here I am using a special system, which is a controlled memory system by HiFlex. It is not a very efficient instrument, but it is highly flexible and it can go easily in this S-shape anatomy to clean it well and to do a nice obturation. Another anatomical situation are the merging canals. It is also a type 2 configuration of Bertucci, but what you can see on the obturation on the final X-ray, lots of anastomosis in the apical part. That's why, and this is the cleaning part of my lecture, it is very important for us, it is essential for us to do a very thorough cleaning with activation, because in the part where we have this anastomosis, it is not possible to go with instrumentation. Even in the part where we have lateral canals, we cannot go with instrumentation. So we need to do a cleaning and an activation of the cleaning. And this is not specific to lower sevens. We can it on upper 7. This is a case of an upper 7, for example, a retreatment case. And look here, on this X, you can see what when I am doing the suction, this is the palatal, the suction on the palatal, and here I am doing the suction on the buccal, and you can see how the liquid goes on the other buccal. It is in that way you will be sure that there is communications between these two canals. And even in the obturation phase, I like to use a technique of a squirting obturation, because with this technique we have lots of pressure. So we can go inside this anastomosis. We can do it first on one canal, and then here I am using the Obtura 2 system, but we can use any other system. As you can see at the end, we can fill very well this canal very properly and have this kind of final X-ray. So for the cleaning, very important to use new also. Here I am using a great tool, really a great one, which is the Irreflex new needles. These needles, as you can see on the photo, are flexible, first of all, and as you can see, they are tapered. So they give a very nice flow. Look at this debris coming out from the canal here, from one of the canals. It's a lower premolar with a deep split with two orifices in the coronal part. Look, it is beautiful to see on the microscope how these big debris from the instrumentation that we did, what we did, are coming out from the canal. So at the end we can have clean canals, and this is the final obturation. Irrigation, even with needles like Irreflex, is not enough. We need to do activations. We can do sonic activations. Here I am using ultrasonic activation, Look at this. It is beautiful to see how the liquid is activated with this endo-ultra system, which is a PUI system, and doing cavitation and acoustic streaming, removing debris and all the smear layer that we have inside these canals, and to be able at the end of the obturation to clean all the canals, meaning not only the main canals but also the lateral canals on the left and on the right side of the root. So to end my lecture, I have a few messages. The important thing is to expect always the unexpected. And this is the easiest way to deal with the anatomy, with difficult anatomy. Not to forget, like this painting done by my great Lebanese painter, Laure Ghraib, not to forget that every tooth is different from the other. Here you can see every face is different from the other face. And finally, what we need to do is to bring what is unpredictable to the predictable way, a feasible way and a teachable way, so we can teach what we know to other dentists and to other students. Thank you very much. Thank you.